All, this is Dr. Mobeen Sayed from drbeen.com. Today we are going to continue once again with the COVID-19 pathophysiology. I had made an error yesterday, which I think was sufficient to redo this lecture. So I'm going to take away the lecture that I did yesterday and I'm going to redo it. So my apologies if you have already watched it. There is one error that I want to correct. And let's start our discussion. So it is really a recap of majority of the discussion yesterday. However, one error that I had made, I'm going to correct that. So let's start. And welcome everyone. As I said, in yesterday's lecture, I had made an error, which I think must be corrected. So I'm redoing the lecture from yesterday and fixing that error as well. I'll tell you up front, the error was that I said the angiotensin 1 to 7 is converted from angiotensin 1. And actually, angiotensin 1 converts into angiotensin 1 to 9, and angiotensin 2 is further converted into angiotensin 1 to 7. But I cannot go and edit that previous video. It is live on various platforms. So I had to redo the lecture today. So my apologies that you're going to have to listen to my discussion from yesterday once more, but I think it is worth it. It's a good review as well. And it is a holistic, complete review too. So let's start. So the pathophysiology of the coronavirus or SARS-CoV-2 can be divided in multiple sections. The very first section is the destruction of the cells because of the infection by the virus itself. So if I have a cell over here, so let's say this is an epithelial cell in our respiratory system, when the coronavirus, when the SARS-CoV-2 connects with the ACE2 enzyme here, and remember we call it ACE2 receptor, but really it is an enzyme, but coronavirus uses it as a receptor. So it binds here, we all know that, and the result of that is that the coronavirus envelope fuses with our cell's membrane and the RNA is injected into the cell. That RNA in turn gives rise to more viruses, replication occurs, and then finally those viruses are ejected from the cell. In this process, the cell will die. And there are a couple of reasons that the cell dies. One reason is that when the virus is ejecting from the cell, it may break the cell on the way out. And that breaking of the cell would, of course, kill it. The other possibility, so this is one. The other possibility, can anybody tell me what would be the other possibility? Now you're all cool beans, immunologists as well. The other possibility is that the natural killer cells of the immune system, innate arm, natural killer cells will figure out that the infected cell does not have correct amount of proteins on its surface, which means that the cell is not healthy, the inside machinery of the cell is not working correctly, and the natural killer cell is then going to kill this cell as well. So I see over here Siddhartha said killed by natural killer cell, absolutely correct. So these are the two primary reasons. Of course, as the immune system overall starts reacting as well, that means the whole of the immune system becomes activated, which may take anywhere from 7 days to 14 days. Then there are more things that would start killing these cells that are infected. But in the beginning, this is what is happening. So this is one reason for the cell to die. The second reason is that when a cell becomes infected, the cell starts secreting various interferons, most importantly interferon beta, which will ask the neighboring cells to become strong and up their defenses. And coronavirus has this interesting thing that it sends its own cargo, its proteins, inside the nucleus of the infected cell and prevents that infected cell from releasing interferons, which causes the neighboring cells to kind of not know what is going on, and they become now a prey, an easy prey without any defense, to become prey for the coronaviruses to arrive in them. So cellular defenses are reduced or compromised as well. So these are the two primary ways where coronavirus directly attacks and kills the cells, or becomes the reason that the cells are killed. Then, after that, the second thing is the ACE enzymes, or the angiotensin imbalance. And this is where I had made a mistake yesterday that I'm going to correct now. So let's look at it. What happens is that normally our kidneys, they release renin, correct? This renin acts on angiotensinogen, and angiotensinogen is released by liver. When renin acts on the angiotensinogen, it converts it to angiotensin 1. This angiotensin 1, when it passes through the pulmonary vessels, in the lung vessels, in the blood vessels of the lung, so if I make a small, tiny blood vessel here, imagine this is in the lungs. In the pulmonary system, the blood vessels have abundant ACE enzymes on their endothelial cells. So ACE enzyme, we can call it ACE1 as well. This ACE enzyme is going to convert angiotensin 1 into angiotensin 2. Angiotensin 2. I'm just going to write ANG2. This angiotensin 2, as we had discussed yesterday as well, is number one, it causes vasoconstriction. And that is a normal phenomena, that is a normal healthy process. This vasoconstriction is necessary for us to maintain our blood pressure. So as kidneys are looking at the blood pressure, they would release various amounts of renin according to the need for the blood pressure to go up or down. And based on that, angiotensin 2 quantity will become more or less. So vasoconstriction would occur to help us maintain the blood pressure. Secondly, we know that angiotensin 2 is pro-inflammatory. It is pro-inflammatory. And what does that mean? What it does is when the angiotensin 2 attaches to the AT1 receptor, so if I make a cell over here, so let's say this is a cell on which there is an AT1 receptor. This receptor is for angiotensin 2 molecule, ANG2. When this binding occurs inside the cell, we have reactive oxygen species produced. Those reactive oxygen species would cause damage to this cell. Plus, when they are released from the cell, they would cause the damage to the surrounding cell as well. Plus, they would cause macrophage activation, or the immune system will become active when it will see damaged tissue pieces because of the reactive oxygen species. So that is the start of the inflammatory process. Now, this inflammatory system is checked, it is balanced, because in the blood vessels, there is another enzyme which we have been talking about for a long time, and that is the ACE2. So let's say this is another blood vessel here, and that has this endothelium. On that endothelium is ACE2 enzyme. This is the same enzyme that is picked up by to which the coronavirus attaches. When angiotensin 2, so here is my correction from yesterday. I said that angiotensin 1 converts, but it is really the angiotensin 2. When angiotensin 2 connects with the ACE2 enzyme, then the ACE2 enzyme will convert angiotensin 2 into angiotensin 1 to 7. This really is sort of a deactivation of angiotensin 2. Angiotensin 1 to 7, in turn, has opposite actions to angiotensin 1. What does that mean? It causes vasodilatation. Vasodilatation, that means it relaxes the blood vessels. So that is opposite to vasoconstriction by angiotensin 1. Plus, it is anti-inflammatory. So now angiotensin 2 got converted into angiotensin 1 to 7 by ACE2 enzyme, which then angiotensin 1 to 7 is vasodilator plus anti-inflammatory. So that means there is always a balance between the angiotensin 2 and angiotensin 1 to 7. And that keeps the healthy balance between pro-inflammatory system and anti-inflammatory system, vasoconstricting system and vasodilatation, and we have a healthy system. Now what happens is, when the coronavirus invades our body, coronavirus starts using ACE2 enzyme over here as its binding receptors. That causes the ACE2 enzymes to become less in our body, or they go into the cells with the coronavirus. So sort of they're not available to convert angiotensin 2 to angiotensin 1 to 7. This results in, of course, now imagine we do not have enough ACE enzymes to convert angiotensin 2. So that means more angiotensin 2 is present in the body, which would mean more vasoconstriction plus more inflammation. Now this inflammation in the vessel wall would cause injury to the blood vessel wall, which would then lead to hypercoagulable states, which we'll see. The second problem is that the counteracting molecule, angiotensin 1 to 7, is also reduced. So not only the pro-inflammatory molecule is more, the anti-inflammatory molecule is less. So that potentiates the pro-inflammatory effects of angiotensin 2, and the damage becomes more. So this is a very important thing, and this is where I had made an error yesterday. So back here, what would happen is that ACE2 enzymes are destroyed, which will result in less angiotensin 1 to 7, and which would also result in more angiotensin 2. And we talked about what would happen. Here is what will happen. When there is more angiotensin 2, that would cause more inflammation by reactive oxygen species, which would, number one, cause the immune system activation or macrophage recruitment, plus vessel wall damage, plus other tissue damage. So that is where the damage starts occurring. Now, ACE2 enzymes are present abundantly in kidneys, lungs, GIT, heart, blood vessels, and brain. So these are the tissues that are at risk. Of course, blood vessels are a primary area, although lungs are the first target of the coronavirus. So the disease starts from the respiratory systems, but then it can involve other areas, most importantly blood vessels, then heart as well, then kidneys as well. And as you know, that some people would actually have the symptoms started from GIT, gastrointestinal system, because the virus went into their stomach, and virus has a lipid glycoproteins around the virus, which protects its envelope from getting destroyed by the stomach acids. And then the virus can connect with the ACE2 enzymes in the GIT and cause infection over there as well. So that is how the damage starts occurring. So I hope this part is clear. So there's a question, when we discuss ACE2 converting to angiotensin 1 to 7, can you clarify if angiotensin 1 to 7 actually contains several enzymes, or is that just a name protocol? I think this is just a naming protocol. It may be a molecule with multiple facets on it, but this is one molecule. So good question. Now continuing on, further damage by the virus. The further damage is that the virus can also now trigger the immune system to become extra overwhelmingly activated. Now this does not happen in everyone. It is about 19% of the people amongst us that will respond overwhelmingly. So far, there are no labs that can identify those folks that would respond that way. For example, look in allergies. We know that in allergies, what happens is that there is a percentage of our population that would react to, for example, pollen or dander or dust or other such allergens, and they would react to them abnormally, while the rest of the population is not affected by them. So this is why we say we have allergy. Now, for allergies, we have tests now. We can do labs for the allergens to figure out our body reacts to which allergens, and then we can say you are allergic to following things. For the COVID yet, we do not have any labs yet. I am sure that we will develop such labs where we can look at the immune system to say this person's immune system is going to react overwhelmingly and we need to protect them more. So we don't have those yet. Hopefully we would have those testing systems as well available. So when the macrophages become overly active, so some people call it cytokine storm, some people call it macrophage activation syndrome, others call it cytokine release syndrome, and there are other names as well. So then what happens is systemic tissue damage starts occurring. When the immune system becomes dysregulated, when the immune system becomes mad, now it is not just contained in the lung, it is going to go, the cytokines and the chemokines are going to release and go into the rest of the body, and they would activate the immune system wherever they go, and that would cause a systemic damage as well. So systemic tissue damage would start occurring. The patient can then go into a septic shock. Septic shock is basically organ failure that has started because of lack of the blood volume coming to our tissues. And the reason for that is very simple. It is a fatal situation, but the reason is very simple. What happens is, so let's say here is our blood vessel. When the cytokines and chemokines and other inflammatory molecules, when they are released in the tissue, eventually they would come into the blood vessels as well. And they can now start causing the blood vessel cells to react differently. Plus, they would activate the immune cells in the surrounding, which would eventually cause the blood vessel itself to start becoming damaged. Now, when the blood vessel walls are damaged, that would cause the fluid that is present inside the blood vessel. So let's say this is blood. I should make it red, but let's just call it blood for our purposes. This blood or parts of blood, not blood itself, but the plasma and the other fluids, they are going to start oozing out. When they would start oozing out, what would happen is that the fluids are now ejecting from the blood vessel, from our circulatory system, and accumulating in the tissues. Now, when they accumulate in the tissues, for example, in the lungs, fluid accumulation would cause acute respiratory distress syndrome, which is almost a fatal situation. Additionally, when the fluids are getting out of the blood vessels, then the amount of fluid inside the blood vessel is less now. So blood volume is less. And that volume that has become less would reduce the blood pressure, the oxygenation and the nutritional supply to the remaining part of the body would now start dropping, which would then result in the septic shock. And the organs would start failing. So low blood pressure with the organ failure is called the septic shock. So back here, when the immune system starts going mad, that would cause not only tissue damage, but that would start setting in the septic shock. Once again, I would qualify that this septic shock does not mean that it would happen in everyone. There is only, I shouldn't say only, there are 19% of the people who respond to this and then who have this. And then unfortunately, 3 to 5% of the people would end up in the critical state, and about 3% would die as well. So it is quite a serious situation. Then, of course, we talked about the tissue damage. One tissue especially that is important is the lung. So lung damage causes hypoxia, lack of oxygen, and accumulation of carbon dioxide in the body, which is very, very damaging because we work with oxygen to make our energy and to function. So when there is no oxygen, the cells are going to start dying. And yesterday I had made a comment that when there is less oxygen or when there is hypoxia and ischemia, that causes the cells to swell up. And there was a comment on YouTube that can we prevent the cells from swelling up? So let me first explain what does cell swelling means, and then explain that how to try to fix that. Of course, you provide oxygen and nutrition and the cell would start recovering. So here is what happens. So let's say this is a cell. A cell needs energy not only to function, but also to maintain itself. So ATP, so remember we need glucose or nutrients, plus we need oxygen to start making ATP, which is the energy. This energy, these tiny batteries, are not only used to make new things in the cell to function, but they are necessary to maintain the integrity of the cell as well. So when the energy levels start going down, the cell cannot maintain its cellular membrane very well. It cannot maintain its internal organelle or the small machines in the cell very well. Plus, when there is oxygen that is less, that causes the cell to do anaerobic respiration, or it causes it to make energy or ATP without oxygen, which also produces lots of lactic acid. And the amount of energy produced is lower as well. So this lactic acid in turn is damaging to the cell as well. So the result of that is that the cell organelle and cell channels that are in the membrane. So let's say here is a channel. This channel, let's say its job is to keep the internal and external environment constant. And so there are thousands of kinds of channels that, for example, sodium channel, potassium channel, chloride channels, calcium channels, and so on. Just like we have zinc ionophores, which are channels for zinc, similarly, we have other channels as well. And the cell is always maintaining the electrolyte balances. So when these channels start failing because there is not enough energy, the cell cannot maintain its electrolyte balances, which means that the water can start seeping in and start getting trapped inside the cell. This water inside the cell is going to start swelling the cell up. Plus, the damage to the membrane would start making holes in the cell through which the cell content would start spilling. So first, the cell starts swelling up. Then the cell becomes damaged and it starts spilling its contents out. Once the cell starts spilling the content out, it is gone. It is dead. But when the cell is swollen, the question yesterday on the comment was, how do we prevent or can we reverse that? So yes, we can reverse that by giving it oxygen and by taking away the lactic acid. So how do we give it oxygen and take away the lactic acid? We bring more blood over there, which is highly saturated with oxygen. So that means you fix the lungs, plus you fix the blood pressure and blood volume, and that would wash away the lactic acid and that would bring in more oxygen. If that happens and cell has not reached a point of this membrane destruction, then the cell's situation can be reversed. So that was the answer to the comment yesterday. It was a good question. So the lung damage occurs. So this is the third one. Direct damage to the cells, that is one. Secondly, the ACE2 and ACE1 to 7 imbalance that causes pro-inflammatory system and activation of the immune system. Then thirdly, the immune system itself becoming activated. Now, fourthly, and this is the long hauler, and you know that I've been talking about long haulers for some time. So the fourth issue is that the patient may actually combat the virus, take care of it, but still have persistent mild symptoms, annoying symptoms. And that could be, as we discussed before as well, the reasons could be the following. Number one, so let's say long hauler. And this is my conjecture because I haven't yet seen any studies. I'm sure that studies would come out soon. I haven't yet seen any studies that exactly say what happens to long haulers. So I'm going to think aloud with you in medical terms. So look, one possibility for persisting symptoms is the extensive tissue damage. For example, let's say there is extensive lung damage. Just like there is a wound, let's say there is an injury on our finger, that injury would not heal in one day. Even if there was infection and that is gone, the healing would take some time. So similarly, let's say the lungs became damaged. So even when the virus has been taken care of by the immune system, the damaged lungs would need some time to recover. So let's say blood vessels got damaged, or heart got damaged, or kidney got damaged. So that damage would need time to recover. And in some cases, that damage would never be recovered. For example, the fibrosis in the lung. For patients who are on ventilators, the fibrosis in the lung in some patients would never recover, and they would always have to stay dependent on oxygen. I know patients who are on ventilators, they have now come out of the situation. The virus has become negative, but they are now ventilator dependent because their lungs and their chest wall is not sufficiently capable, and the lungs have fibrosed enough that they are not able to breathe, and you have to push air into them by force, by ventilators. So they need rehabilitation, and they have a long road towards recovery. So that is one reason. The second reason is possibly immune dysregulation continuing. And is that possible? Yes. The autoimmune diseases, for example, or dysregulated immune system happens in all of us. The allergic situations are actually dysregulated immune system. The rheumatoid arthritis, for example, is a dysregulated autoimmune system. So immune system can become unstable and then stay unstable for a longer time. So if that would happen, then the immune system would keep attacking our body and then keep causing damage and will keep having symptoms. A third possibility is that the residual virus is still present. Now that is just that the virus has not fully cleared and it would clear out within 1 month, 2 months, 3 months, or that is because the person has become a carrier, which is still not very clearly understood. There may be both situations. So that may be because the virus is still being eliminated, or that may be because we have become a carrier. In all of these situations, a person may have the symptoms even after that they recovered from the primary disease itself. So back here, so that is the fourth mechanism by which the damage occurs. Now let's look at the systemic view of it. And so let me just look at one comment over here. So Terry says, good evening. If taken early in the onset of the virus, would an H2 blocker, famotidine combined with H1 blocker, antihistamine, slow down the progress? So Terry, from the discussions I've done about the famotidine, it seems like it helps. It doesn't need to be with the antihistamines or not, but it seems like it helps. The question is that what stage and how much help? So those things are not yet quantified, but it is part of the Math Plus protocol. It does help. Okay, so now let's look at the systematic view. The first thing is the respiratory system damage. Look, the respiratory system damage, and there is a question here. Hello, Dr. Bean. Heart damage. I would think one would not feel well if the heart muscle is taking a while to heal. Absolutely, and I'll talk about that in a second. So let's start from the lung damage now. So I'm going to go over the tissue damage now. We know now 4 ways the damage is occurring: the virus causing destruction of the cells. Then secondly, the ACE1 and ACE2 angiotensin 2 and angiotensin 1 to 7 imbalance. And thirdly, the immune system overreaction. Fourthly, lingering virus and immune system and tissue damage continuing. Now let's look at individual organs, lungs or respiratory system. So we know that in majority of the cases, if the respiratory symptoms appear, and I'm saying if because in many people anosmia occurs, or in some people headache occurs, or burning of the eyes and the irritation of the eye occur. In some people it is only the GIT symptoms. In some people it is just the myalgias and fatigue and restlessness occurs. And nowadays I'm hearing a lot of people with the neurological symptoms. So it is not necessary that it is always going to be the respiratory issue, but typically it is respiratory system issue. And normally it starts from the upper respiratory system issue where sore throat and cough appears first. Runny nose is a rare situation. Then if it progresses further, then the virus starts going deeper into our airways and into the lung tissue, and that is when the pneumonia starts appearing. And the way the pneumonia occurs, and because we have done these discussions many times, I am hoping that these things are on your tips now. So what happens is, so let's say this is our lungs, and inside the lungs, we have the airways that are dividing and dividing and dividing. And we know that the final airways, they become alveoli, they end at alveoli, and near the alveoli are the blood capillaries, which have blood in them. And between the alveoli cells and the blood capillaries is the connective tissue. This is the respiratory barrier. Virus normally starts, and most of the viruses do this, they normally starts infection from the interstitial tissue or the tissue between the airways and the blood vessels. Because of this, the person is actually infected, the cells are actually getting destroyed, but the alveolar system, the airway system is still intact, and there is no congestion, there is no edema that is occurring, there is no blood spillage that is happening, and that causes dry cough. So there is no sputum that is being produced. This is very common for the viral infections of the respiratory system. We call it atypical pneumonia, or we call it walking pneumonia, because the person is actually walking around and he feels okay, but they have pneumonia going on. And if you take a chest X-ray, you would see pneumonia there. One outcome of the viral infections of the respiratory system is shortness of breath. Why is the shortness of breath? Because this barrier starts getting damaged. Imagine that oxygen has to go from here all the way into the blood, and it has to cross this green area, which is a connective tissue. And if the virus is present over there and this area is damaged, then it is possible for oxygen not to cross easily. That is the beginning. Then what happens is, after the atypical pneumonia, the typical pneumonia starts occurring. And what does that mean? Eventually, the immune system plus the virus causes so much damage, both to the alveoli and to the blood vessel wall, that what happens is the blood vessel would start oozing out. This is called congestion. So the fluids would start coming out of the blood vessel, plus the tissue is starting to break in the alveoli. So now alveoli are filled with blood, with pus, with broken tissues, with broken neutrophils, with broken immune system cells, with broken pathogens, and so on. And as this area is now compromised for the oxygen and carbon dioxide exchange to occur, that becomes very difficult. So now plus when this person will cough, they would produce this sputum that would have this pus coming out as well. So now this has become productive pneumonia, or this is called typical pneumonia as well. Most of the time, typical pneumonia occurs in bacterial infections and not in viral infections. But here, this virus is such a destructive entity that it starts from virus-like pneumonia, which is atypical, converts into typical pneumonia, and then if it continues to cause more and more damage, then what would happen is the same pathology that I'm showing you here, this pathology becomes abundant in the whole lungs. It starts from the basilar areas or the lower parts of the lung, and then it just keeps going upwards as well. So now the person has congestion, or the fluids filling in their lungs, and the person is drowning in them. So that drowning in the fluids would of course cause severe compromise of gas exchange, and that would cause severe hypoxia. This is the acute respiratory distress syndrome. So after the acute respiratory distress syndrome, so if you see here with the respiratory system issues, atypical pneumonia would occur, then typical pneumonia would occur, then acute respiratory distress syndrome would occur. Of course, that would result in lots of hypoxia because lung tissue is not working correctly. Hypoxia, or less oxygen, is now going to do a number on the whole body. Everything is going to receive less oxygen now, and every tissue needs to have oxygen to function correctly, as I just mentioned before. So when they do not have enough oxygen, they're not going to function correctly, and the tissue damage would start occurring. And finally, organ failures would start. And so there is a question here that proning the patient reduces the symptoms. Yes, so what happens is, so look at, I hope you can see this tiny picture. So let me actually make my picture a little larger. So imagine these are the lungs, correct? What happens is, if I'm sitting like this, my heart is pressing on the lungs which are behind it. And there is a decent portion of the lung behind the heart. If I lie on one side, for example, my heart is going to press on this side of the lung. If I lie on the other side, my heart is going to press on that side of the lung. So heart is always pressing some part of the lung when we are lying down straight or on the side, with the face up or on the side. Now, if you prone a person, if you make the person lie down with the face down, that causes the posterior part of the lungs to become open, because the heart drops on the sternum or the chest bones. There is no lung in front of the heart. So when heart drops in the front, the posterior part of the lungs get a chance to open up, and that is extra lung tissue that becomes available for oxygenation, and that oxygen would give us energy, and that would give us ATP and help us combat the virus better. So prone positioning is very, very, very valuable. So good question. Continuing on, if I share my screen again. So then is the cardiac tissue damage. I have written 2 reasons over here. There are 3 reasons for the cardiac tissue damage. Number 1, hypoxic damage. Hypoxic damage is that or let's say when the lungs are not working correctly and the oxygen is less, that less oxygen will be less for heart as well. And heart is one of the highest performing tissues in our body, like kidneys are as well. Can you imagine for our heart to rest for 4 or 5 minutes throughout our life? No, we cannot. It has to continue to work. For our whole life, we cannot imagine our heart taking a rest, other than in each beat it takes a rest, then beats, then rests, then beats. But that is all it can do. It cannot just take a rest for a longer period of time. That means it's a very highly performing tissue and it needs oxygen continuously. Now, if there is hypoxia occurring because the lung tissue are damaged, then there is less oxygen for heart's own functioning, and that would cause damage to the heart tissue. Then heart is under increased workload. On one end, you're giving it less food and oxygen. On the other end, you want it to work more. Why do you want it to work more? Because the rest of the body has less oxygen as well. And the body is crying out, the body tissue is saying, I need more oxygen. So how do we compensate for that? Number 1, we ask the lungs to breathe more, so the heart breathing rate goes up. Secondly, we ask the heart to pump with more force. Thirdly, we ask the heart to pump faster with a higher rate. All of that increases workload on a heart. So now think about a heart which already is compromised because of less oxygen, and now you're whipping it and asking it to work faster as well and work with more power as well. It's going to start failing. And the third reason for the heart to become damaged is because heart tissue has lots of ACE2 enzymes as well, to which the coronavirus would bind, and it can go into the heart tissue and start becoming toxic to the heart itself. So these are the 3 reasons why the heart becomes a target and becomes damaged. Again, it doesn't happen in everybody, but 19% of the people. This is also why the folks who have cardiac issues, they would be more vulnerable to this virus or COVID-19 because their heart is already compromised, and now you're going to put more load on it to work, plus you're going to damage it with the coronavirus, and that is going to compromise the heart further, unfortunately. So that is the heart. I have discussed this thing in the past, and again, I'm very happy about this one topic, that we are covering almost all 100 of the videos with various mechanisms into this one little recap. The other issue that occurs is that I forgot. So let's continue and it would come to me. Yes, so I was going to talk about the hypertension. Hypertension itself is not a direct issue for coronavirus, but still people who are hypertensive are more vulnerable because due to hypertension, they have cardiac damage going on if the hypertension is not managed. Plus, they may have kidney issues going on if the hypertension is not managed. And they may have atherosclerosis in the blood vessels, on top of which, if you damage the blood vessels, so now heart is already compromised, blood vessels have atherosclerosis in them, the kidneys may be damaged. On top of that, if you add the COVID-19, then that becomes an issue as well. So hypertension itself is not a problem, but the consequences of the heart hypertension cause tissue damages, which make tissue weak, and they cannot combat with the virus correctly. Now, vascular damage. We talked about vascular damage as well. So let's just quickly look at it, what happens. So here is a blood vessel. And what happens is on the endothelium of the blood vessel, we have ACE2 enzyme. On this ACE2 enzyme, coronavirus comes and attaches. When that attaches, it would go into the blood vessel cells and it would cause damage to them. Plus, we also know that angiotensin 2 is roaming around unchecked and unconverted to angiotensin 1 to 7. And so that angiotensin 2 is also going to connect with AT1 receptors, which in turn is going to cause reactive oxygen species to be produced, which would then cause damage to the endothelium and the cells below. When that damage occurs, then what would happen is that the cell would start breaking down. When the cells start breaking down, then the broken tissue becomes exposed to the blood system. And blood system, or our blood, and the clotting factors in the blood do not like broken tissue. So what happens is, as soon as this happens, von Willebrand factor becomes a bridge for the platelets, and platelet aggregation start occurring. This is the formation of a thrombus. A thrombus is the clotting that is happening inside the blood vessel. This thrombus would, of course, narrow the blood vessel, and the blood flow to the onward tissues is reduced. That is one. Secondly, the thrombus may break down into smaller emboli, and those emboli would then travel downwards, downstream into smaller blood vessels and go and occlude them. And that would cause necrosis and ischemia of the tissue below. And that would damage those tissues as well. So severe hypercoagulable state would appear, which would then cause strokes. If the thrombus goes to the brain, it can cause heart attack. If the thrombus goes into the coronary arteries, it can cause COVID toes, where the thrombus would come and get lodged into the blood vessels of the peripheral tissue, like feet and the fingers, and necrosis and ischemia would occur in those areas. So that is the damage to the blood vessels and the hypercoagulable state. Then is the cytokine storm. So we talked about cytokine storm above as well. I want to talk that here as well in the tissue damaged. So imagine that immune system itself is a tissue. It's an organ, let's say, as a whole. Now that has become dysregulated as well because of the virus, and it is just doing madly weird things and causing damage. And we have done lots of discussions around that. So the cytokine storm occurs, and we know what happens with that. Then diabetes and diabetes as a comorbidity. We talked about it before as well. What happens is in diabetes, the cell does not have, so glucose is present outside the cell. So here is a candy, the glucose, it is available. So glucose is everywhere outside the cell, but it cannot go into the cell because the cell is resistant to insulin. So when the glucose is not able to go into the cell cannot make ATP correctly, and cell is in a low energy state. Because of the cell is in low energy state, it doesn't function correctly. If you take such a cell of a diabetic person, which is already at a low energy state, and you ask it to work faster, it is going to break. Similarly, immune system cell of diabetics, which are mostly the uncontrolled diabetes, the immune system cells are not functioning correctly. This is why what happens is that the infections are not easily controlled in diabetics. They're in sort of an immunosuppressed state. So when the immune system is not working correctly, it cannot defend itself correctly from the virus, and that would also cause damage. Then we also know that in diabetes, what happens is that the glucose that is running around everywhere free, it is not able to go into the cell and be used. That glucose is going to start sticking to the tissues and the endothelial blood vessels, and this is like mud on the tissues, and that would cause the tissues not to function correctly. So the tissue functions are destroyed, blood vessels are destroyed, and then the whole system, our body, is in low energy state anyways. So diabetics, especially uncontrolled diabetics, or meaning diabetics that have uncontrolled diabetes, are at a greater risk of the serious situations. Then obesity. What happens in obesity are a couple of things. One is that in obesity, the free fatty acids are more in the body. Those free fatty acids are like wrench in the gear of the insulin system. So what happens is, if we have, this is a cell, and we need to have insulin come and attach here, which would then open up the doors for glucose to go in, the glucose channels. Now, in case of the obese folks, when there are more free fatty acids and they go into a cell, they would cause the internal machinery of the cell to become jammed up, which allows the glucose doors to open when the insulin is present. So now insulin is present, it is pressing the bell to say, hey, open up the insulin, the glucose doors, glucose wants to come in, but the free fatty acids are jammed up in the wires of the bell, and the bell is not ringing, and the doors are not opening, and glucose is not going in. So in obese folks, diabetes is common. And somebody had put a comment, so redoing the lecture has one advantage. I could see what people's comments were and address them. somebody had put the comment that not every obese person is diabetic. Correct. Not every obese person is diabetic, but obesity does lead to diabetes. So number one, there is diabetes. Number two, there is inappropriate, or there is dysregulation of liponectin, which is a autocrine hormone that is released from the adipocytes or the fat cells. When that hormone becomes low, then that hormone is normally anti-inflammatory. When the amount becomes low, then there is pro-inflammation or pro-inflammatory behavior of the body. That is, more inflammations would occur, more damage would occur more. Then we talked about the children yesterday. This is the last part of the topic today. And we have seen this, that the children are less prone to serious disease. That doesn't mean children do not get infected. That doesn't mean they do not spread. That doesn't mean they're immune to this disease. It is just that luckily, fortunately, they have milder symptoms. They can manage the disease better, but still there is 0.2% chance of death as well. So one child can die out of every 500 children who become infected. Now, why do children have better outcomes? The reason for that is, number one, they have less ACE2 in their oropharyngeal area. So because of that, virus finds less places to bind and go into the cell. Secondly, they have more natural killer cells compared to adults. And natural killer cells are first responders. They're part of the innate system. They originally are part of the adaptive system, but they broke ranks from there, came into the innate system, and now they're working as the cells that would destroy the infected cells. So children have better natural killer cells, which would very quickly take care of the infected cells and contain the infection. Then children have better trained immunity. So in the immune system, we have two arms, innate arm and the adaptive arm. When the adaptive arm becomes active, that is B cells and T cells, they can become memory B cells and T cells. However, innate arm cells do not become memory cells, but they do change their DNA expression to be able to combat with the same virus more easily if it arrives in our body again. This is called trained immunity. They become trained to respond to this virus in the future. So children have better trained immunity because they become infected again and again. And finally, children have better cross-reactivity as well. Because children get too many respiratory infections compared to adults, they have their immune system that might, let's say, work with the human coronavirus in a child that causes the respiratory system's issues. And then the immune system antibodies that are present may cross-react with the SARS-CoV-2 as well and capture it much earlier. So children have better cross-reactivity as well. So that is the discussion. My apologies that I had made an error yesterday and I had to redo it, but I wanted to make sure that this video is done correctly because it is a recap of all the pathophysiology. I'm going to now remove yesterday's videos. So please, if you have shared those links, please know that they would not work, or I'll probably just unlist it and I would keep this video up. So there's a question that am I talking about the children under 5, 10, or 18? So look, the situation is this. Children under 1 year of age, and I've done a complete discussion around this. I would like you to look at that video. I have discussed more thoroughly over there. Children under 1 year of age can get more infections. Children between 1 to 10 may have less infection and may have less, they combat it better. But again, how better, we do not know very well. Children from 10 to 16 years of age, they have 0.2% death rate. And then above that, as the age increases, the risk increases as well. So this is the discussion for today. Tomorrow we have open forum. Please put your questions here for the open forum and we would discuss them, or put the questions on my Twitter account and we'll discuss them. My request to you, please like, subscribe, and share. Thank you very much. And I'm going to remove the previous day's videos. Have a good day.